Hello. Yeah, thank you very much, Dr. Twinkle, for having me in your wonderful course. And I'll be speaking about advances in the optical biometers. We all know that in today's modern era, uh, can can you just play the slideshow, please? Yeah. So, refractive cataract surgery is the most common surgical procedure performed worldwide, we all know. And to achieve better outcomes in today's era, the surgeons, they are really dependent on precise and accurate biometry of the eye. For many years, the gold standard of excellent measurement was ultrasound biometry, but then the optical biometry was introduced in 1999, so which was highly accurate and non-invasive device to measure the axial length of the eye. We all know that if there is a difference in zero point 0.3 millimeter in the axial length, it amounts up to the 1 diopter difference in the IOL power calculation. So axial length measurement is the most crucial step in the ocular biometry. We all know that. So previously we were using, as Dr. Tejas said, applanation biometry, which has been obsolete now, and immersion biometry, A-scan biometry, a lot of people are still using because of the cost factor of the optical biometers. But why optical biometer scores over this A-scan, this is biometry, is because the A-scan uses the frequency of 10 megahertz, and the resolution of the accuracy of the A-scan biometry is to the 0.1 to 0.12 millimeters, whereas optical biometers, they are accurate within 0.01 millimeter. So they are 10 times more accurate than the ultrasound biometers. And this difference is also because the A-scan ultrasound, basically, when this ray of the ultrasound it hits, it measures from the internal limiting membrane of the retina. And then what it does, all the machines, they averages out the retinal thickness, which varies from 160 to 400 micrometer, and they take an average of 200 micrometer to all the measurements. So, but optical biometer, it measures the true retinal thickness. So optical biometers, all the optical biometers, they measure up to the retinal pigment epithelial layer. That's where this accuracy of the optical biometer comes from. So as you see here, this ultrasound biometer, they measure from the internal limiting membrane, whereas the IOLMASTER or all others optical biometers, they measures at the level of the RP or the Brooks membrane. So obviously there are advantages that it measures the exact thickness of this retina to the RP level, and all the biometers, they use as a different source of the light, which I'll just discuss. And of course, another advantage is that it's a non-contact method, so it doesn't interfere with the keratometry also, because if you put the paracane, the keratometry also changes. So, and then moreover, in patients who have silicon-filled eye, or patients who have the optical biometry doesn't changes in those patients, whereas these ultrasound waves, they travel with a different speed in different media, so we need to do some adjustment in those cases. So it's also advantageous for the cases which have silicon fill. So basically, what all these optical biometers are based on this. So the first optical biometer was this IOLMASTER 500, which was based on the principle of optical interferometry, and it was introduced in 1999. So what is done in this is that it uses a 780 micrometer infrared light, and this ray of the light, when it goes and it hits this partially reflecting mirror, which is placed here, this incoming coherent light, it converts it, like it get deviated into two identical beams because of this, and the phase difference between these two light, when they come together, it measures the optical path difference, and which gives us the measurements of the ocular tissues. So before going on to details of each optical biometer, let's see how they also increases the accuracy of keratometry. We all know that the more number of points we measure in the central cornea, the better it is. So this is the manual keratometer, which measures only 2 points and the 3.2 millimeter ring, whereas the IOLMASTER, the older one, 500, it was measuring the 6 points around a 2.3 millimeter zone, whereas the LENSTAR, which came almost 10 years after IOLMASTER 500, it was measuring 32 points. And now we have LENSTAR and OA 2000 and different biometers which also have the T-cone topography along with these measuring points, which further increases the accuracy. So IOLMASTER 500 served almost for 15 to 20 years, and so it used to measure axial length, K, and other ocular parameters by using the PCI technique, that's the partial coherence interferometry. So, but limitation was that it was not able to penetrate through the denser media and patients who had corneal opacity or denser cataract. And then another disadvantage was that it used to measure the axial length with the laser interferometry, but the ACD and other parameters were, because of they were using the slit imagery mechanism, so which was not as accurate as the laser interferometry. So then came the LENSTAR 900 in 2000, and it uses the principle of the low coherence reflectometry. So this was the optical biometer which used the laser technique to measure all the ocular parameters along with the axial length, the ACD, and all other parameters also it was measuring. And it had dual zone K at 1.65 and 2.3 millimeter, and along with it, it also has a T-cone this topography, which further increases the accuracy of the keratometry. And as Dr. Tejas and Dr. Twinkle mentioned, it has iSuite IOL, which calculates the premium IOLs also. So now we have the IOLMASTER 700, which is the latest advancement in the optical biometer. And this was the first optical biometer to incorporate the swept source OCT technology. So it provides a full length OCT image, and it can penetrate the denser cataract also. So we can take readings in almost all of our patients. It also has fixation check feature, which alerts us to a suboptimal scan if the image is captured which does not show the fovea. And it has unique telecentric K and distance independent K measurement system. And it also has different software which includes Higgins Suite software and inbuilt toric calculator. So this is the scan which it gives. We can see the lens tilt, or we can see the foveal pit. If we find that scan is not good, we can again take the reading. And this is the 32 points which it measures by 3-zone keratometry. So it's a very robust machine. So if you look at the differences of the IOLMASTER 500, it uses 780 nanometer light source, it uses at 820 nanometer, and along with the axial length and keratometry this LENSTAR and all these IOLMASTER 700, they also measure the other parameters which are required for the modern formulas. They measure the central corneal thickness, they measure the pupillary diameter, they measure the white to white, they measure the lens thickness, they measure the ACD. So which is required for all the newer formulas which Dr. Twinkle has mentioned, like the Barrett and all those formulas. So and this is the iStar 900, which is also based on the SSOCT technology. It has inbuilt Hill RBF formula in this. And this is the biometer which I'm currently using for last many years. This is the OA 2000 from Tomy. So it combines optical biometry. It has the T-cone topography also. And it's based on the Fourier domain OCT. So it also has very good penetration equal to the IOLMASTER 700. And it also has all the newer formulas inbuilt in it, the Barrett formulas, and it has Shama's PL formula for post refractive surgery eyes patients. Like the IOLMASTER has Hagee's L formula, it has Shama's PL formula. And it also gives all the readings, like what I mentioned, wide to wide, lens thickness, all the 7 parameters it gives. Then we also have the Argus Advanced Optical Biometer, which uses 1060 nanometer SSOCT technology. Then we have ALADDIN, which is a very good biometer. Then we have AL scan, and these are the newer the biometers like Galilei Z6 or the Pentacam AXL, which has come up, which combines the dual Scheimpflug imaging along with the Placido disc topography with the OLCR optical biometry. So the advantage is that if we combine Scheimpflug imaging with optical biometry, it makes suitable for IOL selection in patients who have undergone the keratorefractive surgery, and all the biometers have the newer formulas, of course. So this is the comparison of all the biometers. So thank you very much. With this, I'll end this presentation.